So welcome everyone. My name is Ellen Barra. I'm a specialist with our Provider Outreach and Education Department from WPS Government Health Administrators. On the line with me today is my friend and colleague, Rachel Wood, who will be following our chat and then asking the questions at the end of our presentation. We also have a member of our medical review staff on listening to this. And if there are particular clinical questions that I can't answer, then she may be able to jump in on that. So we're talking today about nursing facility documentation review. On Tuesday, we provided a webinar on the nursing facility evaluation and management rules for billing those services. Our encore presentation should be out there probably no later than the end of next week. We did have some questions that we were not able to answer during the presentation, and we are working on that document to get sent out to all of the attendees. We had a couple of pre-submitted questions, one of which was discussing physical therapy, occupational therapy, and speech language pathology. And this particular presentation won't be covering those subjects. We will be staying with the evaluation and management itself. Another pre-submitted question dealt with the procedure code G0463, which is a facility outpatient charge for when the patient is coming in for an E&M encounter. And that's not part of this presentation today either. We are simply talking about documentation review dealing with evaluation and management services themselves. And then another pre-submitted question that we received that I thought was very interesting was, where does the physician need to keep the documentation for this nursing facility encounter, their evaluation and management service? Can they keep it in their office records? Should it be located at the facility, etc.? So as far as Medicare is concerned, for your billing of nursing facility E&M services, you have to be able to put your hands on it. So whether you have that information within your office, whether it is only within the nursing facility medical record itself, either way is acceptable to Medicare, as long as if we request it, then you can put your hands on it so that you can then submit it into Medicare. So the next slide that we have is going to be our disclaimer slide. And we do include this on all of our presentations. The presentation we have developed for you today is as accurate as we can make it today. However, Medicare rules do change often. So you want to be looking at the rules, the regulations, the CMS website for any final determinations of coverage, along with, of course, your documentation. The next bullet there, we do hope to provide responses to your questions, and we will respond based on the question that you have asked us. Again, Medicare rules will determine the final coverage. CMS does prohibit recording of the presentation for profit-making purposes. So if you are recording or doing screenshots, anything like that, we would ask you to not do that. We are recording this presentation. We will have this available as an encore, both on our website for about 90 days, and then it will also be on our YouTube channel at the same time. So what we're doing here today in this webinar is we're examining real live education or real live documentation that we have received, that WPS has received, and we are going through that documentation to determine the level of services that we can submit into Medicare. Now, when we have gone through this documentation, we have examined this, both myself, Rachel, and then our contact with medical review, and we have come up with levels of service. As with anything else though, and especially evaluation and management services, because they can be more subjective. If you are down coded, for an example, on a procedure code, either through a medical review or through the cert contractor, you can request an appeal. Now, when you request that appeal, your best practice is to identify where it is in the documentation that you believe supports the procedure code that you have submitted. Unfortunately, what we receive a lot of times in our requests for appeals for evaluation and management is a statement that says, we believe the procedure code, whatever it is correct. See the documentation. Well, the problem with that is that we've already seen the documentation and we've already made a determination of the lower level of service. So what you want to do is you want to identify in that documentation where you believe it supports the higher level of service. So really what you're doing there is you're pointing us in the direction that you want us to look at within that documentation. If it's simply a copy of the documentation we've received previously, then for the most part, Medicare is going to come up with the same answer that we had previously, whether that's, again, from a cert review, the comprehensive error rate testing program, or through an WPS medical review. So let's start in then on example number 1, and we have history here. So you can see we have a 73-year-old male seen for follow-up. Now, the procedure code that was actually submitted for this was a new patient, and you can see that identified on this document also. So we really can't tell whether this is a follow-up to this particular stay within the nursing facility, or whether it was simply a patient that the physician had previously. So what we would be looking for in that kind of situation are internal edits to determine whether or not this provider has billed an initial patient procedure code during this stay. If they have, then of course we would deny that service and ask that the provider resubmit that using a subsequent level of service. So it states here that the patient is doing well. The provider is indicating that there are no nursing staff concerns. The review of systems does identify superficial abrasions of the lower legs. It identifies that there's no weeping, no ulcerations, and just a trace edema bilaterally for this particular patient. If we look at the next slide, then we have medications that are listing. We do have indication that it's a medication review where the practitioner reviewed and reconciled these medications with the patient. We also notice on here, if you look, and it's right in this section here, for this particular drug, it's identifying that they want the nursing staff to hold this if the patient's pulse drops less than 60. We also have the acetaminophen that is listed, but the documentation really has not identified any pain or fever for this patient. Now, the acetaminophen is listed as needed. Just, you know, an FYI, we didn't have any pain or anything else listed in there. So now we have information here on the exam. Notice again, there's no mention of any type of pain. Under the skin exam, the lower extremity abrasions are not mentioned. And you can see over here, let me get my cursor to work again, right over here in this section where we have a handwritten note. From this information, I really believe that this is a coder going back to that practitioner to say, okay, why didn't you mention those abrasions that were mentioned before under the skin. Now, they do have some of that mentioned in the extremities, which is that's fine with Medicare, but probably should have been mentioned in the skin also. Under the neurologic, it shows that the patient is alert and they are walking in the hallways without any difficulty. Under the next slide here, we have information here on the treatment. So we've got the venous insufficiency that's listed there. Notice that this is indicated as stable. We have the congestive heart failure that's listed. Patient seems to be fairly well compensated. Continue with the medication. We have information there under number 3, though, that I found kind of interesting. This is the persistent atrial fibrillation, and again, it mentions the drug. You'll notice here, though, that it does not mention anything about watching the pulse here. Now, that information is over there in the medications, but I think if it is not here also, it could be fairly easy for the nursing staff to kind of miss that. So that was just something interesting I found when I was looking at this. And then under number 7, it indicates that the patient is stable and without any significant changes from the last exam. For this particular encounter, it was billed to Medicare as a 99306. And again, that's that new patient procedure code. When we were looking at this, we determined that the procedure code really, the more accurate procedure code was a 99304. When we looked at the problem, we determined that this was low, and the way that I looked at this was that it was 2 or more self-limited or minor problems. Remember, when we're talking about problems, the AMA has a definition of chronic, which is that the condition is expected to last at least 12 months. So that could be 12 months before, it could be 12 months in the future. This documentation does not give us any indication on the heart failure, so it doesn't tell us how long the patient has had it, nor is there any information on how long the patient is expected to have it. We don't have any indication of time within the documentation, so we would not code based on time. We don't have any review of external notes or any orders for any type of testing. So the data then, that level would be straightforward. We do have moderate risk, as the documentation does support the provider is watching the use of that, I'm going to have to try and pronounce it now, metoprolol for that patient's pulse. So this is something that the physician is identifying is a risk to the patient if that it could cause that patient's pulse to drop, and therefore they have provided instructions that if the patient's pulse is dropping below 60, then they need to hold this medication. So based on that, we assign this as a moderate risk to that patient from that prescription, that individual prescription drug management. So based on this, then you have to meet 2 out of 3 in order to choose your level. So we did code this as a 99304. Again, it was billed to us as a new patient. In a couple of cases, it does indicate follow-up, indicates the statement no changes since the last exam. So again, if a provider had already billed an initial for this stay, then Medicare would have denied it and they would have needed to bill under a subsequent procedure code. So now let's look at example number 2. So the patient does have multiple things kind of going on with them at this point, but the provider is really treating the patient for the wounds. And so that's the problem that they are addressing. This shows that the patient also has diabetes, has hyperlipidemia, and has I'm sorry, I can't talk this afternoon, has muscle wasting. But we want to keep in mind what the AMA definition of a problem analyzed or addressed is, and that is that this is the problem that the practitioner is concerning themselves with. Now, you can have additional problems that may either affect the problem that they're addressing, or the addressment of that problem could affect something else. This information really doesn't identify that for us. So it states here that they're doing wound care follow-up and treatment then of multiple wounds. So now we have information here on the notes, kind of the exam. It also gives some instructions to the nursing staff to continue the supportive care, to make sure they're repositioning the patient. The patient needs to be using pillows or wedges. They need to float the heels and apply the soft heel lift boots. Continue proper nutrition and hydration. It also indicates there in the constitutional, patient appears comfortable. There's no acute concerns today, and that's just part of the exam that they have provided. Next, we have information on the first wound. So it provides information on the wound size. It indicates that the wound bed consists of 40% slough, which, really just sounds pretty gross to me, but, I know that happens. And so the patient is denying any pain with the examination. There is moderate drainage from this area with pressure. And then it provides information there to the nursing staff about how the wound is to be cleaned, and then what to do if it becomes soiled or dislodged. Next, we have information on the second wound. Now, notice on here that the top part indicates that the wound bed consists of 100% dry slough. However, the second paragraph indicates that there isn't any. So that kind of would make a reviewer kind of look at that and say, okay, is there really slough that's there or is there not? This also provides the information on the exam of that wound, and then again, the instructions to the nursing staff that go along with this particular wound. And then we have information on the third wound. Again, this is a little different in the fact that it's an abdominal open wound and lies under the PEG tube button. It gives us information again on the size of this. It gives us information on the tissue. We've got 100% hypergranular tissue. Again, patient is expressing no pain with the examination. And then it identifies that the surrounding area is fragile, but without warmth, swelling, pain on exam, redness, etc. And then it gives the information to the nursing staff on how to treat this particular wound. We have laboratory information here. We have a CBC that has been reviewed. We have a PHQ-9 score that has been reviewed. And then notice on here also the risk of complications. The practitioner is indicating that the risk to this patient is low. So on our findings for this one, you'll see here this was submitted as a 99307. However, we determined that the appropriate procedure code, would be the 99304. For problems, we do not have any indication as to whether the wounds are better or worse. We don't have any indication on how long these wounds have been present. And so I compared this to one acute, uncomplicated illness or injury. Again, the medical record did indicate that the patient had additional diagnoses, but there's no indication within this medical record about the practitioner addressing any of those additional problems or identifying how those additional problems would have affected that wound care, either causing it to be worse, or the treatment could be causing one of the other diagnoses to be worse. So for data, we had low because we had the two tests reviewed. These were the CBC and the PQH9. Your testing, when we're talking about ordering tests and evaluating tests, it doesn't have to just be a lab test or a radiology service. For example, the PQH9 is a test for that patient also, and so that does count as a test that has been reviewed. Because the practitioner indicated that the risk was low for this patient, that's what we went with for this service also. The American Medical Association, or the AMA, does indicate that the practitioner should be showing the risk to the patient from the medical decision making that has been made. Since that practitioner has identified this as low, that's what we went with. So therefore, since we have a low problem, low data, low risk, the procedure code 99304 or 304 would be the appropriate procedure code. So now we have example number 3. And this provider was called in to treat the incision dehiscence. And on this same day, the patient was also had a virtual visit with the surgery service. And so we have a history here of what's been happening with this patient. So we have the problem with the surgical incision. They're identifying that the history was obtained from the patient, from the medical records and the nursing notes. And it goes back through the history where they did the exploratory laparotomy with the small bowel resection and the anastomosis. They did the primary repair of the umbilical hernia. So then we have the fact that the patient was discharged. He was in stable condition. He was readmitted back to the local hospital due to this acute pulmonary embolism. He was discharged, he went back to the facility, and then he presented back to the ED for chest pain, and they were again discharged in stable condition. So now we have a situation where this patient's incision is starting to come apart, and it appears that it happened the day before, and so now they're following up on this. Nursing reports that there are no fevers. Patient is denied drainage, redness, or pain. Now, the provider here has looked at medical records. They have talked to the nurse, but there's no indication in here that the patient is not able to provide an adequate history. So that may become important a little bit later. I will have to tell you, when we're talking about this particular example, for those of you that are out there listening to us today that are looking at these medical records, I do not envy you. When I pulled up this particular medical record and started going through this, it did provide a picture of the wound that was coming apart. I was not prepared for that. And I have to tell you, I had to get up and walk away from my desk for a minute before I could come back and look at that again. It was not a pretty sight. So then we have information on the review of systems. We have negative for fatigue, appetite changes, etc. We have respiratory, which is positive for shortness of breath, and the patient is on oxygen. However, we also have information there under the exam, under respirations, that the patient's respirations are easy and non-labored at rest or at rest. Under the abdomen, we do have soft, non-distended, non-tender. So we have an exam that we have available here for us. Then we have information specific to the wound exam itself. This is indicating that there is abdominal pain with that wound manipulation. It shows that the provider did a debridement procedure performed on the same date, and it is showing here that the wound is stable following the procedure. We have assessment and plan that is listed. You'll notice here that the provider does indicate they spent 45 minutes of time. The record, however, does not show the separate time for the procedure, the wound debridement itself. So this is indicating the evaluation and management service, this 45 minutes, along with the time for the actual procedure itself. This also shows that they want the patient to start on this triad ointment, and this ointment itself does not require a prescription. Now, for this particular patient, we have a second provider who's doing a service on the same date. And these two providers were the same specialty, so it did hit edits when it came into Medicare. So this documentation leads us to believe where it says, today I am seeing the resident for a regulatory visit. So we could make the assumption then that this is one of the federally mandated visits. Now, as we talked about in the webinar on Tuesday, there are differences between the federally mandated visits and then also the medically necessary visits. A patient is required to be seen either by a physician or a non-physician practitioner within certain time frames when they're patients within either a skilled nursing facility or a nursing facility. And those federally mandated visits, your best practice is for your physician to identify it, as such, because then we're not looking for all of the medical necessity information that we would be looking for a service other than that federally mandated. So a patient must be seen every 30 days during the first 90 days of their stay, and then every 60 days thereafter. One of the acronyms that they have on here, it says, and it's in bold, it says he has full DMC, and that's decision-making capacity. They mention a hemoglobin from 7/24 of 23. This date of service is 7/31. We don't have any information about who ordered that hemoglobin test, so we really can't determine from this whether that was counted in a previous encounter with this patient or whether it was ordered by someone else and now this physician is reviewing it also. We do have information about the wound care nurse practitioner who also saw the patient on this same date. And we don't know how long the patient has had the chronic respiratory failure with hypoxia, and we don't know when the TIA or the stroke happened. Again, that goes back to those chronic, the definition of chronic. And then, of course, it also tells us that they have no acute concerns today. So it indicates that the patient's medical records were reviewed, including medications, family histories, and were updated as appropriate. They're also indicating that the staff have no concerns for this particular patient. We have the physical exam here, which is giving us our vital signs. We have You'll notice here on the abdomen, there's no mention of the wound. Again, we have soft, non-tender, non-distended, positive bowel sounds. Under the extremities and the skin, we also have no mention of the wound. The patient had the wound at the time of this service. Our previous example told us that that happened yesterday, the day before this visit. So I would really have expected to see some indication in this physical exam of that wound problem. We have orders for this patient. You can see there that synthroid was increased for this patient back in March, and orders were given at that time to check the TSH. However, that was not completed as ordered. So therefore, the physician is ordering a TSH test today for this for this patient. There were no problems, no new problems that were found. So in this example, we have two nurse practitioners, who provided a service on the same date. Now, for Medicare purposes, we consider the same provider as either the same person or a member of the same group with the same specialty. Both of these nurse practitioners were part of the same group, and they were within the same specialty. So therefore, we're not going to pay separately for both of these practitioners. So what you would need to do then is to gather up this documentation to determine the procedure code that you have. So when we're looking at this, we looked at this as the wound problem, the opening of that previous incision. And that is being treated by someone other than the surgeon or a member of the same group with the same specialty as the surgeon. Since this was just found, there would be uncertainty in the prognosis. We don't have a high-level problem, as we don't have any information on how long he had the hernia. The second visit by the other nurse practitioner did not list any exacerbations or any other type of information concerning the status of the problem. Under the data, we have one test that was ordered, that was the TSH. Under the risk, we do have a decision for the debridement. We have additional ointment or drug for the treatment of the wound from that first doctor. We don't have any information on risk to this patient from that second practitioner. We evaluated the documentation based on both, since again, they're the same specialty in the same group, and these services were provided on the same date. Medicare rules indicate that evaluation and management services, multiple evaluation and management services provided on the same date are generally not going to be paid separately. When we evaluated this documentation, we did decide that the E&M supported a significant, separately identifiable E&M in addition to the wound treatment that was provided. So the way that we coded this then was with procedure code 99305 with a modifier 25. And you can see there we identified this as moderate with the one undiagnosed new problem with uncertain prognosis. And that goes back to that wound kind of coming apart there. For data, we have straightforward because we had only one test that was ordered. And then under the risk, we decided this was moderate with the decision for the debridement and the order of the medication. And then, of course, is this wound now going to stay together? Is it going to keep coming apart, etc.? So now we go into example number 4. And example number 4 is a discharge service. The patient is moving from a nursing facility to a hospice facility. This provides history for us with advanced Alzheimer's with behavioral disturbance. The patient also has COPD, depression. They reviewed medications and discussed patient care with the nursing staff. We have information on the review of systems. You can see there the neurological is what we provided to you, and then all of the other systems were negative. We have information on the history for this patient. And one of the things I found interesting when I was looking through this, we have the metabolic encephalopathy, we have abdominal aortic aneurysm, we have hypertension, hyperlipidemia, and all of these are identified with an onset date of April 1st of 2023. Evidently, that was not a very good day for this patient. And I bring this to your attention for a couple of reasons. Number one, when we're talking about problems, again, this is a discharge visit, so it's a little bit different. But when we're talking about problems, and especially chronic problems, those dates become very important. How long have they had the abdominal aortic aneurysm, for an example? Was it really identified on April 1st, or is this the history from this facility, and this is the date that the patient went into this facility? So that's just something you want to think about when looking at documentation and working with your physicians and practitioners on these chronic conditions. Again, AMA's definition is expected to last at least 12 months, either has or expected to, and so those dates then become important there. We have the necessary medical examination, or we have a medically necessary examination for this patient. And it provides us with their vital signs and then additional information on what they examined. And then we have the discharge information. So it's identifying that the patient is being discharged to that hospice facility. It identifies the discharge condition with the weakness, and then it identifies the instructions. Patient is being transferred to another facility based on a family request. The patient does need full assistance for their activities of daily living, and then the family member is aware of that. Now, they identify that the risk of complications for this patient is high, but because this is a discharge management service, we need to be looking at the time. So they identify the time for us there at 16 minutes. So this was submitted as a 99315 procedure code, and then that would be correct for this. Now, one of the things that I thought about when I was looking at this documentation also, and this is just kind of an FYI for you, is the hospice care. Medicare's benefit for hospice coverage is that the patient has a life expectancy of 6 months or less. Now, nothing in this documentation provides us with this information, nor do we have any documentation that shows this individual provider ordered the hospice, but that's just something you want to keep in mind if you're talking about hospice services for the patient. And so in example 4, it identified the 16 minutes that was spent on the discharge management. And so then that correct procedure code is the 99315. So next we want to go ahead and open it up for questions. Rachel has been following the chat for us. So Rachel, do we have any questions?
Right, we have a couple. So our first one is regarding time. So, and I believe this is related to the first example. So if documentation in a topic includes time, I'm sorry, let me just reread this because it's kind of lengthy. If a provider always charges based on time, could they do that? Basically, it's kind of to summarize this question, if time is documented.
And yes, the answer, that's exactly right. When we were going through this documentation, because the physicians did not identify time, then we chose our level of service based on the medical decision making, the problem, the data, and the risk. In example 1, if the practitioner had identified that they spent X amount of minutes on this patient on that day, and that X amount of minutes went with procedure code 99306, then we would have coded it that way. You don't always have to use time to choose your level of service. You don't always have to use medical decision making. You're going to use the one that is more advantageous to you. So, if the practitioner had identified time, then we would have evaluated that also, and we would have coded based on which one was more advantageous to the provider. Next question.
All right. Can you clarify example 2 findings that state 99307 subsequent, but your appropriate should be 99304, which is initial. If that makes sense to you. If not, could the person clarify?
And it could be just my mistake on that one. I moved it to an initial procedure code. The information, well, okay, and I don't have all of the procedure codes in front of me. 4, 5, and 6. No, a 7 would have been a subsequent procedure code. So I think this one is simply my error. That I looked at the procedure code as a new patient as opposed to a subsequent patient. But the level of service then, I believe in 99307 is the same level as a 99304. Thank you for noticing that. Next question.
All right. If you are a specialist doing a nursing home visit, do you see them every 30 days for the first 60 and then every 90 days thereafter as well?
Not necessarily. The patient does have to be seen every 30 days and then every 60 days thereafter while they're in the facility, whether this is a skilled facility or a nursing facility. If you are a specialist who is treating one aspect of that patient's care, you are not required to see the patient that often. Your services would be based on the medical necessity for that individual patient. So for an example, if you're a wound care practitioner or infectious disease practitioner, and one of the things that's going on with that patient is an infection, we'll go back to that wound problem that we had previously. If that patient is not experiencing any problems with infection, or the care and treatment that you're doing for that patient does not require an additional medically necessary service, then as the specialist, you're not required to see them on that same time frame. The time frame that we talked about, those federally mandated visits, are requirements for that facility that the patient has to be seen that often while they're there within the facility. And that kind of brings up an interesting point. Also, one of the questions that we had in our webinar on Tuesday had to do with frequency of services. And when you're providing a service to a patient within the nursing facility, again, other than those federally mandated services, it has to show the medical necessity for the service itself. Not just the patient's here, therefore I'm seeing them, but the actual medical necessity. What problem are you addressing on that particular day, etc. Next question.
That is all the questions we have.
Okay. Well, you can, Rachel is going to enter a email address within our chat function. If you have additional questions that come up following this presentation, you can certainly submit those. We will do a document back to everyone. On behalf of Rachel and myself and the provider outreach and education team of WPS, we want to thank you very much for your attendance. Please be watching for those additional presentations we're going to do. Later this month, we're going to do home, the rules and regulations for home E&M, and then we will also do a home documentation review similar to what we have done now. So thank you for your attendance, and this now completes our presentation. You can disconnect.